Hello, today we are discussing indications for cardiology consultation, guidance for nurse practitioners and PAs. The learning objectives are to summarize major categories of cardiology consultation indications. This is based on advanced practice providers referral guidelines from 2020. First indication for referral is symptom driven, such as chest pain that is suggestive of ischemia or positive stress testing. We can use certain examples such as the Marburg heart score. In this, you give 1 point each for the following criteria. Age, for men more than 55, women more than 65 gets 1 point. Known vascular disease gets a point. Chest pain worse with exercise gets a point. Pain not reproducible by palpation gets a point. Patient assumes the pain is of cardiac origin gets a point. If the total points are 0 to 1, it's low probability. If it is 2 to 3, it's intermediate probability. 4 to 5 is high probability, in which case consider EKG testing and referral. Now, these are the results of the Marburg score, and it shows that if the score is higher, then the outcomes of major events are higher. Now, the chest pain type can also be defined as typical angina or atypical angina or non-angina. If the pain is substernal pressure or ache, if it is provoked by exertion or stress, if it is relieved by rest or nitroglycerin. That is typical angina. If two of the three features are present, it's atypical. If less than one of the three features are present, that's non-anginal. This is called the Diamond-Forrester classification. You could use either one of these. Now, in this chest pain example, in the study called PROMISE, they started out with 10,000 patients and did functional testing on 5,007, anatomical testing on 5,000, and then all of these were evaluated in a central core lab. And basically, they found that um, depending on the kind of pain, as it is shown here, non-anginal, anginal, or typical angina, the percentage of people that had abnormalities were different from men and women. But as you can see, for typical angina, a lot of patients had findings on stress testing and CT. So the history is validated. Then there's online calculators for chest pain for figuring out the pretest probability of CAD. You can go to the CAD Consortium QXMD calculator, for example. Okay, so the clinical decision flowchart is as follows. In the first step, evaluate the chest pain type. The second step, apply a calculating table. And then step 3, determine the pretest probability range. If the pretest probability is less than 5, reassure. If it is 5 to 70, order a stress test or coronary CTA. More than 70, refer to cardiology or consider angiography. In practice, you can pair the Marburg or Diamond Forrester with the CID consortium for a better calibration of risk. Okay, the next indication that is symptom driven is syncope or unexplained dizziness with arrhythmia suspicion. So here's some example syncopes, and basically you use a score called the EGSYS score to assess whether or not the syncope is cardiac. Now, this graph shows the light yellow line is vasovagal syncope. The black line is no syncope. So vasovagal syncope and no syncope have similar outcomes. The red line here is cardiac cause. So if a syncope from a cardiac cause, there's significant drop in the probability of survival. The EGSYS score, a score more than or equal to 3 identified cardiac syncope with a sensitivity of 95 and specificity of 92. Actually, sensitivity of 95/92, specificity of 61 to 69% in the derivation, the validation cohorts. Okay, the components of syncope score, the EGSY score include abnormal EKG that gives you 3 points, the presence of palpitations prior to syncope gives you 3 points, syncope with exertion gives it 4 points, syncope in a supine position gives it 3 points, prodromal symptoms or vasovagal symptoms gives you minus points. More than 3 points makes it vasovagal. Okay, now continue to exertional dyspnea. Exertional dyspnea is shortness of breath on exertion. It's a subjective sensation of breathlessness or air hunger during activity. It may represent cardiac ischemia, also occurs in pulmonary disease, and you have to do a structured assessment of this. First, you start with the history, onset and progression, acute versus gradual. PE would be acute, coronary disease, COPD, anemia, etc. would be gradual. Exertional threshold, quantify the activity that makes you short of breath. Associated symptoms such as orthopnea, paroxysmal nocturnal dyspnea, chest pain, palpitations, whereas cough would make it more pulmonary. Modifying factors, positional or environmental triggers. Risk factors underlying CAD, hypertension, diabetes, COPD, smoking, obesity, anemia are also important. Then you decide whether it's cardiac, pulmonary, or mixed in origin. Okay, then we move on to the NYHA functional class. Class 1 is no limitation. Class 2 is mild limitation. Class 3 is marked limitation. Class 4 is symptoms at rest. Now, you do a structured history and physical, assess the NYHA class, do basic screening with EKG, chest X-ray, CBC, BNP, NT-proBNP, order an echocardiogram for LV function, valve function, pulmonary hypertension, consider pulmonary testing if appropriate, consider 6-minute walk test, refer to cardiology if NYHA 3 to 4, or progressively worsening shortness of breath, elevated BNP, or dyspnea with ischemic EKG changes, or associated syncope, arrhythmia, or unexplained symptoms. Okay, now next category for symptom-driven referrals is palpitations or abnormal EKG findings. Palpitation is the subjective awareness of the heartbeat, fluttering or pounding. It can represent benign PACs or can be as bad as VT. It's associated with anxiety, thyroid disease, or stimulant use. It occurs in 16% of cardiac outpatients. You get a history, onset, and duration. Rhythm quality, is it regular or irregular? Is it abrupt in onset, gradual in onset? How long it lasts? Triggers such as exertion, stress, caffeine, whether it occurs at rest or in sleep. Associated symptoms such as syncope or presyncope, chest pain or dyspnea, tremor or weight loss, past and family history, or whether they have structural heart disease or sudden death in the family. Then you do an EKG. Sinus rhythm or isolated sinus tachycardia is a low risk. Intermediate risk is minor SCT changes, PR prolongation, incomplete RBBB. High risk is LVH with strain, AFib, Q waves, or left bundle branch block. Very high risk is multiple major abnormalities or QTC greater than 500. The odds ratio for death here is more than 3. Okay. Next category, symptom driven, is new murmur or suspected valvular disease. Any diastolic or late systolic murmur is pathologic. New murmur with dyspnea, chest pain, or syncope could represent valvular problems. Change in character or intensity of a known murmur may indicate progression. Murmur with systemic infection or fever may represent endocarditis. Abnormal echo findings would lead to a comprehensive cardiovascular assessment. The echo stethoscope makes assessment of murmurs easy. The first murmur here is ejection systolic murmur of aortic stenosis. The second murmur here is also ejection systolic murmur of aortic stenosis, showing varying severities here. The longer the murmur, the more severe the aortic stenosis. Now, initial evaluation includes history and physical, up to and 12 lead EKG, baseline labs, consider ambulatory monitoring, escalate evaluation when palpitations occur with syncope, there's known structural heart disease, there's family history. Now, these are all the category 1 symptom-driven referrals. Category 2 is patients with established cardiovascular disease, such as diagnosed heart failure with structural dysfunction, known CAD with recurrent angina post-PCI or CABG follow-up, adult congenital heart disease requiring specialist co-management. Indication 3 are diagnostic and risk stratification, for example, abnormal stress test, echo, or Holter results, high-risk patients with multiple uncontrolled risk factors, consideration for advanced imaging or complex therapeutic decisions. Category 4 is perioperative or collaborative care, preoperative evaluation for high-risk surgical patients, patients with structural heart disease before non-cardiac surgery, co-management scenarios with multidisciplinary care teams. In all of these, you should assess functional capacity. For example, can you eat, dress, or walk around your house is 1 to 2 minutes. Can you walk 2 to 3 blocks or climb a flight of stairs is 4 minutes. Can you do heavy housework, carry groceries upstairs or garden is 5 to 6 minutes. Can you run, swim, play tennis, or climb 2 flights of steps briskly is more than 7 minutes. Now, you can use a Duke Activity Status Index or DAISY. If you Google it, you'll find it. There's 12 items and it lets you categorize meds. If it's less than 4 meds, the surgical risk is higher. The 6-minute walk test, if somebody walks less than 350 meters, then that is less than 4 meds. Now, when to refer? If the functional capacity is less than 4 meds, they need cardiology evaluation with non-invasive testing or a stress test. If there's poor activity with abnormal EKG or a murmur, then echocardiogram with a cardiology consult. If there's an unexplained exercise intolerance, assess for pulmonary anemia, deconditioning, or cardiology referral. Now, if someone has more than 7 meds, such as jogging, tennis, excellent risk, proceed to surgery. 4 to 6 meds, stair climbing, brisk walk, light housework, adequate, proceed if asymptomatic. Everybody else needs cardiology referral. Pre-referral checklist includes complete history, focused cardiac exam, EKG labs, and echo. Document the referral question. This is important, and the goals you expect from the referral. Ensure appropriate urgency level, emergent versus routine. Emergent referral for ACS symptoms, unstable arrhythmias, acute heart failure. Urgent for worsening angina, new AFib. Routine is stable follow-up of chronic cardiac conditions. Communicate findings and plan clearly with cardiology. Integrate recommendations in longitudinal APP care. Ensure closed loop communication for patient safety. Okay, here's a quick example case. 58-year-old with new exertional chest pain, abnormal EKG, needs cardiology referral. 45-year-old with diabetes, LV dysfunction, echo, needs cardiology referral. Discuss the decision-making, referral rationale, and the co-management approach with the patient and put in your note. There could be over or under referral. There may be institutional differences in scope and workflow. and it's important to maintain up-to-date referral knowledge. The key take-home points: recognize red flag symptoms, refer appropriately, maintain the communication follow-up, and stay aligned with competency frameworks. That's all for now.